And I'd like you to give a warm welcome to Dr. Jeff Rubin.
We're going to shift bases a little bit and go to the arterial system. One of my favorite areas is carotid surgery, and because I'm old, I do a lot of complicated stuff, a lot of redos, and so we'll go over some of the basic pathophysiology of carotid disease, and we'll wander into some other areas that most surgeons prefer to stay out of. Carotid artery disease, as everyone knows, is primarily due to arterial sclerosis. We also occasionally see a patient with fibromuscular dysplasia, which is kind of a scarring, almost looks like a bunch of muscles coming up the wall. We see kinks and coils unusually. We see aneurysms, and we see arteritis, which are due to inflammatory disorders. And thankfully, we don't see many cases in the last 4. Going back over some of the basic pathophysiology, we look at plaques differently. Part of the problem we have in medicine is all the carotid artery disease papers you review always talk about percent stenosis. And some of the research that we've done over the years looking at plaque morphology, looking at electron microscope views of the plaques and what we find in them, I've come to feel that the percent stenosis is really overstated, and we really need to look more with our ultrasound views now that we get at the plaque itself. We see a stable plaque. If you look at the slide on the left, you see the lumen is a very small portion on the left, and then you have some thickening or a fibrous cap over it, and then you have a bunch of junk underneath there. And it can either be very smooth and firm, or the more unstable problem plaques, they actually are echogenic, and there's clot that forms underneath the plaque. And we've found over the years that these are the ones that pose a much greater threat for stroke, especially in patients with hypertension. Excuse the blurriness, but I actually had slides taken off and made computer graphics for them. So we look at this slide and we see a thrombosis or clotting off of the internal carotid artery. That's what all the neurologists talk about as percent stenosis. A very small percentage of patients with 50% or more stenosis will actually progress to thrombosis. And if they do, it gives the brain the ability to develop collateral circulation from the other carotid artery or even from the vertebral arteries. So although this is a very lovely side to show, it's something we don't normally see. Now, going back to the plaque morphology, on the left-hand side, you see that little lump there. That's the plaque. And what can happen with the plaque is it can either progress and cause a higher degree of stenosis, or more unfortunately for patients, you can develop a hemorrhage in the plaque. It will then rupture from the hypertension, the constant beating against this area of the artery, and you can have debris shower up into the brain or the eye, or you can be left with a carotid ulceration, which is this depiction on the left side of the artery. So this ulcer crater is a nidus for platelet debris, degenerative plaque, platelet aggregates to all gather and cause a constant source for embolization. So when we look at an ultrasound, a good ultrasound of a carotid artery, you really want to make sure that the plaque is discussed. You want to know if it's a smooth plaque, you want to know if it's an irregular plaque or ulcerated. And then based on some studies done by Wes Moore at UCLA back in the 70s, we want to describe the ulcers as small, large, or multiple, because this may affect how we treat the patient. This is my favorite slide. Back in the late 80s, our head of neurology at Case Western Reserve, he hated vascular surgeons and hated the idea of doing carotid endarterectomy. Back in the 80s, it was kind of controversial because of a couple of studies out of Southern Illinois University in Cincinnati, where it showed very high stroke rates with surgery. So his mother was referred to me for TIAs, and I recommended an operation. And he said, "There is no way in hell you're touching my mother." I said, "That's fine." So she continued to have TIAs, and then she had a stroke, and his brother, he was out of town, his brother was the head of pulmonary medicine in Kentucky. He brought her in and we operated on her while his brother was out of town. And this is her plaque. You can see that it's full of little blood clots and ulcers. This is what happens with an intraplaque that becomes hemorrhagic. That's all blood clot. This is a patient presented with an acute stroke, and we were able to get him into the operating room and get this horrible plaque out before he could have recurrent strokes and have more morbidity. So that's the end result of hypertension hitting an unstable plaque. This is another picture of a thrombus inside of an artery. This is kind of unusual. This was actually not a thrombus, but it was an embolus from the heart. We have to consider other options for people that have neurologic symptoms. Obviously, the carotids are what vascular surgeons like to think about, but the heart also poses a threat for embolic problems. The risk of a stroke, myocardial infarction, or death when you're doing carotid endarterectomies we used to have a number of less than 3% to benefit the patient. It's amazing, we haven't really changed what we're doing with regard to how we operate on patients, but our stroke rates have consistently come down. And my opinion now is that if you have a stroke rate over 1%, you're not doing your patients any benefit. So we obviously want to have good technique, and we want to also make sure that our anesthesiologists are doing what they're supposed to do, and that we have good postoperative care. So there are a number of things we look at, and we'll go over those in a minute. What's entered into our equation in the past 10 years is carotid artery stenting, and I'm going to preface the rest of this talk by saying I don't believe in stenting anymore. We did a lot of stenting, and our results were never as good with stenting as they were with endarterectomy. That's purely a personal experience, and it varies from institution to institution and surgeon to surgeon. And you notice I didn't mention the word cardiologist. Carotid endarterectomy, there's two methods for doing endarterectomy. One is the standard, where we open up the artery, take the plaque out, and usually put a patch on. And then there's eversion endarterectomy, where it's a kind of a different type of operation, where you pull the plaque out by dividing the artery, and it's a different type of procedure that I don't do. It's made famous by the guys in Albany, New York. This is what an artery looks like to an artist. You can see the common carotid arteries down at the bottom. You see the external carotid coming off on the right, and the internal comes off on the left. And you'll see a nerve crossing up above. That's the yellow stripe, and that's the hypoglossal nerve that makes your tongue stick out funny when you move it around. And the vagus nerve travels up the side of the internal on the left. And believe it or not, it's just like the picture, doesn't it? That's a picture we took a couple weeks ago, just so I have a picture for the slide. And you can see that the artery is kind of a different color, and that's because the plaque actually shows through the wall of the artery. And we have the external control with the blue little loops up there, and the internal comes off to the left. Now, we're going to assume, for the purpose of this talk, that you know everything you need to know about primary carotid endarterectomy. What we've grown fond of, and I'm not sure why that's happened, but we seem to get I've got a lot of patients who have restenosis. Restenosis, after your initial endarterectomy, ranges nationally from 1 to 20%, which is really a large range. And I'm not sure why people have 20% recurrences. We have about 1% in our series, but patients we're going to talk about now, what we do with patients who come in who have had a reaccumulation of plaque where it's been cleaned out. Primary restenosis, when it occurs in under 2 months after the initial operation, we assume that's due to a technical problem with the operation itself. If it occurs less than 24 months after the operation, we assume it's due to intimal hyperplasia, which is basically a scarring, a smooth scarring of the artery, and it could be from the clamp entering the artery. It could be due to, things that aren't due to your actual operation itself, but scar tissue can reform under the patch you put on or where you close the artery up with your sutures. If it occurs greater than 24 months after the operation, we usually find this is due to a recurrence of the disease in the area you operated or progression of the disease either above the endarterectomy or below it. When we see primary restenosis, about 65% of them, based on our series, are hyperplastic, which means there's a lot of scar in there. We see about 20% are due to complex or heterogeneous plaque, which is a combination of smooth and not smooth blockages. And then we see about 20% also have thrombus or hemorrhage inside the plaque, and these are referred to as complex. About 75% of the patients we see with restenosis are asymptomatic. So they're usually, after you do an endarterectomy, you follow the patient with ultrasounds regularly, and you're watching for the patient to develop a recurrent problem. And that's how we pick these up in about 75% of the people. We don't usually find them just walking through the door. Now, when you have a recurrence, the problem that the surgeon faces is, do we do it open or put a stent in there? And this is something that's only developed over the past 10 years with stenting growing in popularity. The reason that people are afraid to do a redo operation is that we consider the neck on a redo operation to be hostile. In other words, there's scar tissue in there. It's harder to identify the nerve structures. We also have to consider the location of the lesion. Is it a very distal problem up above areas that are easy to get to in the neck? We also have to evaluate the overall health of the patient, and of course the most important is the skill level of the surgeon. The way we evaluate patients is by carotid duplex scanning, and the reason that's highlighted is based on some research we did back in the late 1980s. We found that carotid, and I'm sorry for the misspelling, so there's an extra L in there. Carotid scanning is used in our series about 95 to 99% of the time without doing any other type of imaging. We find that it's a highly sensitive test, it's a very specific test, and it's accurate. The study we did back then, we evaluated the accuracy of carotid ultrasound, comparing it to angiography, and basically those two modalities were then confirmed by a blind pathologic evaluation where they identified the percent stenosis and described other characteristics of the plaque. So the carotid scanning gives us a good idea about the plaque morphology. It tells us what the stenosis is, and can also identify the areas of involvement of the plaque, so we're not surprised in the OR. A good ultrasonographer will always tell us if there's a high bifurcation, so we're prepared for that before we go into the operating room. A secondary method for evaluating carotids is a CAT scan with contrast. We see a fair number of patients who come to us with these tests in hand. They're usually done in conjunction with other problems, i.e. an ENT surgeon who's evaluating someone for radical neck dissection comes in with a CAT scan showing the severe stenosis in the carotid artery that's been operated in the past. Lastly, angiography. That used to be the gold standard. We probably do less than a half a dozen arteriograms of the carotid arteries a year to evaluate the blood vessels before surgery. This is a carotid arteriogram that shows at the bottom. You can see the common carotid artery. You don't see much in terms of other than darkness between the common and where the internal refills. And this was a patient with a recurrent stenosis that was referred in, and they were concerned because they saw the area of the carotid intracarotid artery, the plaque seems to move up higher than just at the bifurcation. And it's a very nice picture, but once again, it doesn't tell us anything about the plaque morphology. Now, preoperatively, we need to do a lot of different things to evaluate a patient, but most importantly, on redos, we recommend laryngoscopy, and we do that ourselves in the office. And we do that to evaluate vocal cord function. If you have a vocal cord paralysis on the other side and you go in and do a redo operation on the ipsilateral side, you could wind up with a patient with a tracheostomy afterwards. So laryngoscopy is extremely important, and I prefer doing it myself with a slit lamp, kind of old-fashioned. If you have an ENT guy that likes doing them, that's probably a better way to send them. The question number 2 is whether you get a CAT scan before a redo operation, and we do not routinely do them anymore. We used to, and I found 11% of the patients who had CAT scans before we did their carotids had abnormal findings in the CAT scan, and then we didn't know what to do with those patients because they weren't strokes, they were meningiomas, small aneurysms, all sorts of crazy stuff. So we stopped doing CAT scans. Before surgery, carotid surgery, the most important thing, whether it's just a primary operation or a redo, is control hypertension. The worst thing you can do in carotid surgery is take a hypertensive patient who is not well controlled to the OR and hopefully have your anesthesiologist control it. That will never happen. And hypertension out of control in the OR during a carotid is probably the largest group of patients who have stroke. So it's absolutely essential to control high blood pressure. Our operation, we published this series about a couple of years ago. Redo carotid endarterectomies, and our options for surgery include redo endarterectomy, which is taking the plaque out of the artery, and we put a patch on all vessels unless they're enormous. You could do a patch angioplasty alone. We do that sometimes when a patient has real thick, scarred, and smooth plaque, and all we're trying to do is get that lumen back to the size it's supposed to be. And lastly, resection and either saphenous vein interposition grafting, where we take a piece of vein out of the thigh and sew it into the common carotid artery and then the internal distally. Or if we don't have vein to use, we'll take the superficial femoral artery out of the leg, do a short segment bypass with PTFE to reestablish the flow in the leg, and use the superficial femoral artery as the graft conduit. These are a couple pictures of redos. You can see this little plastic thing with the lines across it is a shunt. That's placed in the common carotid artery and then placed distally in the internal carotid artery to keep flow going while we're clamped. We do not use shunts routinely. We use shunts when patients have had a stroke on the side we're operating on. We use them if there's a complete occlusion of the contralateral internal carotid artery. And I, being old-fashioned, still use stump pressures, and we use a 50 millimeter mercury medium pressure for an indication for using a shunt. By all means, these are my standards, not national. There's all sorts of different variations. You can see on this picture there's some interesting findings. So there is a smooth plaque in there, but what's happened is you can also see some blood clot in the bottom of some small ulcerations, and you can see more ulcerations toward the right-hand side. And this is a patient who had occasional TIAs, and the surgeon didn't want to operate because they weren't really anything consistent. So they didn't find anything significant on their ultrasound other than a 75% stenosis that appeared smooth. When we did our ultrasound, our tech thought she found some ulcerations or small ulcers, and that's what we found in surgery, so he was absolutely right, there were ulcers. This is kind of hard to follow. You see this is a third time redo endarterectomy, and you can see how thin the wall of the artery is posteriorly. I wasn't real happy with the way this looked, so this patient then we resected and did an interposition vein graft. Once again, this is another picture. You can see the common carotid artery has been cut on the left-hand side. You can see it divided. You can see the internal carotid artery up in the right-hand corner divided. I always like watching the fellows' faces when cut across the carotid artery. They get horrified. And this is a vein interposition graft. I wasn't extremely happy with the way this thing looked, because the vein looked small, but it wound up dilating up nicely, and there was good flow through, which we used a flow meter in the operating room to make sure that there was good flow through there. Now, the complications of all carotid endarterectomies include hematoma, myocardial or heart problems, TIA, stroke, and restenosis. Those are the main complications we see. We put drains in the necks, and everyone says, well, does that decrease your incidence of hematoma? The answer is no. It just tells us when it's draining fast, you need to go back sooner. Heart attacks, we don't see a lot of myocardial ischemia anymore because most of these patients are pretty well evaluated preoperatively. And if someone has multi-system problems with atherosclerosis, we do coronary stress tests before we do our redo carotid endarterectomies. TIA and stroke, we'll go over that data in a minute. And restenosis we find very uncommon when we follow our guidelines for revascularization. The most significant complication that I find with redo endarterectomies are cranial nerve injuries. The hypoglossal nerve is the most common nerve that gets injured, mainly because we have to go up higher in the neck with redo endarterectomies. So we frequently will control the hypoglossal nerve with a vessel loop, which is a little rubber band, and move it around so we can get up above it. And the hypoglossal nerve injuries are pretty disastrous early on for the patient because the patients usually bite their tongue when they're chewing, and their wives look at their tongue and go, "Oh my God, you had a stroke." But these are local nerve injuries that go away. Vagus nerve injuries, because of the proximity of the vagus nerve in the scarred previously operated area, is a problem. So you have to be real meticulous with your dissection. The marginal mandibular nerve injury, that's the nerve that crosses the jaw and causes the lips, the corner of the mouth to sag, and so of course everyone runs around and said, "Oh, they've had a stroke," and once again you say, "No, it's just the marginal mandibular nerve," and that's from a traction injury pulling the jaw up during your operation. The rest of these nerve injuries are really unusual. The cranial nerve injuries in our series, 80% of them were temporary and they recovered within 30 days. 16% were prolonged and did recover, but it took longer than 30 days, and 4% were permanent. And a permanent cranial nerve injury is not the best thing to have depending on which nerve you get, but we still find that to be acceptable given our long-term results with the operation. With our 192 redo endarterectomies, we had 0 strokes, 0 deaths, and 1 patient had a myocardial infarction and recovered from that. That was based on troponins. Our incidence of cerebrovascular events after carotid stenting, this is from the National Cardiovascular Data Registry, and this is why I stopped doing stenting. Our cerebrovascular accident rate after stents was about 2% as well, and our rate is obviously better with surgery, so we stopped stenting. Less than 1% of our first-time carotid endarterectomies develop recurrence, and I think that's mainly because we are very aggressive at using patch angioplasty on almost every artery. It's very rare that we don't put a patch on them. 1.5% developed significant recurrences, which basically these are other areas. Other reports range from 4.6% to 11%.